Oops. All right. We're going to wrap up our last 2 hours. We'll obviously break between this hour and the last hour. I'm not going to keep you for 2 in a row. We would all die. But we're going to wrap this up with a discussion of nephro, uro, repro. This lecture talks about kidney, but really it gets into male repro. And then the last lecture, we'll talk about some female repro. When we talk about repro conditions, I know you haven't had that block yet, and so that feels really scary, but I want you to know that a lot of the repro discussion and conditions are repro light on the NPLEX exam, meaning that a lot of them you can logic your way through a lot of the answers. So when we present them, I'm going to present some of the ones that aren't so easy to kind of like walk your way through. The STDs, STIs, I'm not going to present as part of the lecture because really you just need to know the bug associated. So we're going to talk more about in the repro section at the end, female repro, the cancers, the weird tissue types, the tumors, the cysts, the CINs, those type of things that are a little bit more tricky and hairy when asked about on an NPLEX exam. So this whole last 2 hours will kind of merge into the repro discussion. So when we talk about nephro and uro though, a couple of things to keep in mind. If they give you hematuria and it's painless, it's bladder cancer until you prove it's not. So when in doubt, if there's a hematuria case and they're asking anything about oncology or likelihood of conditions, bladder cancer should be up on your list in regards to this if there's absence of pain with hematuria. But lots of things can cause blood and urine. We're going to look into a few of them. So azotemia, this will see essentially increased BUN in the blood will be present. You can differentiate the site based off of creatinine excretion levels. Typically, the kidney has to be sick to have creatinine rise to equal BUN. So there's 3 reasons that you can see kind of this azotemia discussion. You can have prerenal, intrarenal, and postrenal. Prerenal, think about things that impair blood flow into the kidneys. BUN and creatinine will both rise. BUN will rise faster. You can see a healthy kidney with a low GFR because it's stuff that's affecting things going into the kidney that's the problem. It's not the kidney itself. It's prerenal, pre-kidney. Intrarenal is actually injury to the glomeruli itself, injury to the tubules, injury to the small vessels. It is in the kidney that is affected. You'll see both BUN and creatinine equally high, equally elevated. So the ratio will look normal, but both will be up. And then post-renal, you're thinking obstruction, stone, mass, something that's obstructing obstructing the flow out of the kidney, typically urine flow. Labs can be tricky for this one to identify post-renal. Typically in these type of test scenarios, they're not asking you a lot about lab results, so that's good. But recognizing depending on what the etiology is going to depend on the site that's being affected. So don't try to memorize the list, just think logically. If it's something before the kidney, it's not path of the kidney, it's prerenal. If it's something in the kidney itself, that's intra. And if it's something after the kidney, that's post. So we deal with types of acute renal failure. We can see prerenal, inadequate renal perfusion, typically from decreased extracellular volume. So stuff that's affecting stuff going into the kidney itself. Post-renal, glomerular and tubular dysfunction or obstruction from a stone, an increased prostate, a tumor, again, something that's after the kidney that's affecting outflow, or within the kidney itself, acute renal failure. We can see ischemia, toxins, acute glomerulonephritis, tubular necrosis, anything that's actually affecting the structure itself of the nephron or the kidney. So whenever you're dealing with acute renal failure, depending on what they give you in the case, they'll often talk about maybe the patient has stones, maybe the patient has a blood pressure problem, low perfusion, maybe the patient has a type 3 hypersensitivity, right? So you could identify, and then they say, now your patient has acute kidney failure, acute renal failure. What's the most likely type based off of their presentation? And they'll give you prerenal, postrenal, renal, and then something that's pretend, a not real word. Okay, maybe they'll make up a word sometimes. And you have to identify based off what they give you, what your kidney failure falls under. Acute renal failure as a definition is sudden loss of the ability of kidneys to excrete waste, make urine, and conserve electrolytes. So you're going to have sudden onset of kind of all of the above. Oliguria, proteinuria, hematuria are your main kind of components that you'll see. Your symptoms can vary, but really acute renal failure, it's that sudden loss versus chronic renal failure is that chronic progression or loss of GFR or filtration rate. So these are kind of some hallmarks that you can see in acute renal failure. And your etiologies are vast. And so that's why I don't want you to memorize them. There's so many options, but anything that essentially affects the ability for the kidney to do its job in an acute scenario, think about where it's affecting the kidney, and that can help you identify your etiology. Okay. Again, another list. More lists. So this is when we get pre-renal, intrinsic. I don't even think I have a post-renal. No, I don't. But again, this is the same list of things I talked about. These are all stuff that can happen before, right? All things that can happen before it gets to the kidneys that can affect the kidneys itself. Stuff dealing with blood volume, stuff dealing with blood pressure, stuff dealing with volume loss, medications that are affecting things. Inside the kidney, you're dealing with things that are actually directly damaging kidney, nephrotoxicity, glomerulonephritis, actual infections, your type 3 hypersensitivities, anything that falls in that category, right? Ischemia, loss of actual oxygenation. These are all things that could damage the kidney itself. Really post, you're dealing with tumors or obstruction or stones. That's post. That's like a whole host of questions you've got down. You just have to find the location of the problem. That's it. I'll often give it to you. So acute glomerulonephritis. So acute nephritis, we often talk about acute post-streptococcal glomerulonephritis caused by our group B strep infection of our throat, strep pharyngitis, a complication of that. We can see red cell casts. You can see this obviously in children, especially if they had strep pharyngitis. You can see moderate proteinuria. And really the etiology is it's inflammation of your glomeruli because you're having these essentially complement, antigen, antibody complexes deposit themselves there. When you have damage to your glomeruli, you're going to have issues with filtering. So that's how you can get blood and protein loss into urine. So you can see anemia because of the blood loss. You can see azotemia because you have an accumulation of nitrogenous waste like creatinine and urea because you damage the glomeruli. And your cast is going to be a red cell cast. It's blood essentially being lost. Yes.
So you said it's cheap, but in US only it says
I misspoke. This meningitis, group A strep pharyngitis, strep. Thank you. Group A strep. Group B strep. Group A strep. Heart too. Okay, there we go. Awesome. So serologic markers, don't worry about these, right? This is not diagnostic class. So I would not spend a ton of time thinking about all these levels at this point. Not high yield for you. Okay. Same with, so GFR, the only reason GFR is helpful is telling you that it could be chronic kidney disease. Again, not a diagnostic class. Just know that anything technically below 90 for GFR could classify as a chronic kidney disease, depending on if you have other symptoms. That's the only place where they could get you, because we typically think of chronic kidney disease as anything below 60, so 59 and below, but that's stage 3, 4, and 5. Stage 1 and 2 is technically above 60, but you have some symptoms, either proteinuria, hypertension, abnormal kidney anatomy. You have something else that has to occur with a lower GFR to count as chronic kidney disease when you're above 60 for GFR, glomerular filtration rate. Chronic renal insufficiency, again, you're having issues with filtration. You're having inadequate filtration of your kidney, so it's insufficient. This is where you can get your metabolic acidosis. You can have issues with anemia, azotemia. You can have inadequate potassium excretion or absorption, phosphate issues, calcium issues, protein issues. Really think about anything your kidneys are filtering and processing. And if you're doing it at less of a consistent rate, an insufficient rate, you're going to see issues potentially in the blood. It's going to depend on the severity of the disease. The common causes we can think about with chronic renal insufficiency is diabetes and hypertension. These are probably the most commonly asked about on your test. The actual failure of the kidney is going to be because of the accumulation of fluid in the body and accumulation of waste products in the body. So think about ammonia and urea. You'll see creatinine increasing, BUN increasing, creatinine clearance increasing, and you may even have hyperkalemia. Okay. UTIs, the only thing I really want you to think about with UTIs, obviously think about E. coli, but if there's any bacteria at all in the urine, that's abnormal, right? Urine should be sterile. So if they mention bacteria present in the urine, that's wrong. That's an abnormal thing. That's an infection of some kind. There's no normal flora of the urine, right? Really important things here would probably just be bugs. Your main bug is E. coli, but also recognize Enterobacter, Klebsiella, Enterococcus, Pseudomonas, Proteus. These would be other kind of more common bugs to see as a urinary tract infection. They will give you some other characteristic. So they'll give you a Gram stain or some other characteristic of the bug itself in question if they're asking about something that's not E. coli, not the most common associated. So urethritis or cystitis is your acute UTI. Your classic is going to be bacteriuria, pyuria, potentially hematuria. Symptoms, you're not going to take diagnosis, so I'm going through that pretty fast. Contrast this with interstitial cystitis. This is inflammation or irritation with increased presence of immune cells to the tissues of the bladder, but no infectious cause. It's not associated with infection. So this is a great way for them to try to pull you because they use cystitis. But if it's interstitial cystitis, there's no infectious cause, is associated with an inflammatory irritation of the bladder itself. You can still have same symptoms. You can have dysuria, urinary frequency, urgency, discomfort, pain with dyspareunia even. But if they culture it out, they won't find any infectious etiology. That's the big difference. Typically, you're looking for Hunner's lesions inside the bladder via cystoscopy. That's Hunner. It's not always seen though. So you can have IC without. You also could look at pinpoint bleeding due to inflammation or irritation of the bladder lining. Think about like gastritis, inflammation of the lining of the stomach. Interstitial cystitis is the same thing. It's just of the lining of the bladder. Okay, polynephritis, medical emergency because it can lead to kidney failure. Essentially, we have a UTI that's ascended up the ureters to the kidneys. So that's what when you get pyelo. More common in females than males, just because UTIs are more common in females than males. So if we have more UTIs in females, because we have a shorter urethra, so it's more likely that bacteria can get into the urethra, into the bladder, we're more likely to have them ascend. Some other reasons that could potentially lead to compression that could potentially predispose that bacteria to move up, pregnancy, or even benign prostatic hypertrophy, BPH. That's more due to renal or like urinary stasis because you're not fully clearing the bladder. But essentially you're having inflammation in the renal pelvis. That's what this condition is associated with. So when we're dealing with urethritis, inflammation of the urethra for men, specifically male pathology, we're concerned with gonorrhea and chlamydia as being the main etiologic agents, so our common STDs. You'll see this present as dysuria, purulency, frequency in urination, almost kind of like a UTI for females, plus discharge, purulent discharge from the urethra. Other agents besides gonorrhea and chlamydia, ureaplasma and E. coli could be seen, but I would say gonorrhea and chlamydia are going to be your most common etiologic agents, specifically gonorrhea the most. It could spread to the prostate or epididymis. You could see an acute prostatitis or an acute epididymitis, an infection of the prostate or epididymal structure. You could see an ureteritis from an HSV, from a herpes simplex virus infection. It typically is more slower to onset or relapse and remits, much like the actual external lesions would. Syphilis as an STD for either males or females, but typically with males or females, there's 3 stages: primary, secondary, and tertiary stages. Tertiary is the worst stage. It's obviously could have neuro involvement. Primary and secondary stages are typically more localized in nature. With syphilis, the chancroid is your big kind of pathognomonic lesion. It's a painless ulceration that can occur with syphilis infection. With penile inflammation, we can see, we'll have a little bit more on some of these male conditions here in a moment, but penile inflammation, balanitis, typically in patients with phimosis or some redundant prepuce or prepuce, this typically is seen with a staph, E. coli, or candida infection, mainly because those are the skin lesions or digestive lesions or topical conditions that are like local to the area. That's probably what they would ask you about, would be the type of bug associated most of the time. Penile tumors, this one is where you can, we could also see this called condyloma acuminatum, HPV 6 and 11, so different HPVs than we see in like cervical cancer for women, but 6 and 11 are the HPV strains that are more commonly associated with penile tumors. Typically, these are benign and they are sexually transmitted because they're associated with HPV. Okay, now we get to some of the more fun conditions to talk about, because they love to test these and make us compare and contrast all of them. I have my little extra notes. So we have our hypospadius and epispadius. These are congenital misplacements of the urethral canal. It could be either ventral or dorsal. It could be or could not be associated with undescended testicles. Often the complication is urinary obstruction or inability to inseminate, so issues with infertility. Okay. When we're dealing with, let me see here if I have anything else to say on hypospadius or epispadius. Nope, that's all I have to say. Okay, great. Phimosis, with phimosis, you often see the orifice of the prepuce is too small to permit retraction. This could also lead to inflammatory fusion of the foreskin to the glands. This can be obviously pretty painful. It can be severe in some instances and can lead to potential need for emergency transport. Yeah.
That's also physiological.
Yes, absolutely. Can be physiologically normal. Only issue if you have that inflammatory fusion. Yeah. Paraphimosis is the prepuce is retracted and won't replace. So it's retracted and won't move back forward. Other male pathologies that are helpful to note, Klinefelter's or cryptocurism. We already talked about Klinefelter's tons, but male hypogonadism, you have 2 or more X chromosomes and 1 or more Y chromosomes. Cryptocurism, it's undescended testes. That's what you're dealing with. Typically, it's unilateral. And even though if it's corrected, you could have an increased risk of infertility and testicular cancer. I'm pretty sure I talk about this one later, but if I don't, I wanted to mention it here. This is kind of a DDX for differential diagnosis for acute scrotal pain. I do talk about all of these in my repro lecture. So I'm going to skip this table for now because we do go through all of them, epididymitis, all the way down to orchitis. But if you're a table person, the comments and clinical findings can be helpful here. Epididymitis and orchitis, typically associated with lower UTI or prostatitis. Gonorrhea or chlamydia in men is common if they're under 35. E. coli and Pseudomonas is more common if the male is over 35. Mumps could also be an etiology, typically seen 1 week after onset. So really for either of these conditions, knowing your bug based off of age of male will be the most helpful high yield piece. And this is just depending on where we're actually seeing the swelling or the inflammation. Obviously, in the epididymis, we're dealing with inflammation of the epididymis. If we're dealing with orchitis, we're dealing with inflammation of the testes itself. Epididymitis, you're going to see more localized pain and tenderness over that posterior testes where the epididymis is. You'll have a Friend sign, which is PH or PREHN sign, where you have pain with elevation of the scrotum. This epididymitis can progress to involve the whole testes. You can have a progression to orchitis. Orchitis, you're going to see full testicular pain and swelling. And again, mumps orchitis specifically increases risk of infertility post-infection. And I think when it comes to etiologies, yeah, the chlamydia and gonorrhea are made too common for young males, E. coli, Pseudomonas for old males. There is an autoimmune component as well. There is an autoimmune epididymitis or orchitis that's less common. Okay. So all of our seals then, we have our varicocele, we have a hydrocele, there's a spermatocele. So when it comes to our varicocele, varicocele is a scrotal varicosity, an abnormal dilation, and it's tortuous, tortuosity of the pampiniform plexus of veins. It's almost always on the left side because there's more issues with drainage on this left side than the right side. And it can cause infertility, especially even after it's corrected. It looks like a bag of worms appearance. It's your classic clinical finding of your varicocele. Versus your hydrocele is an accumulation of serous fluid in scrotum. So it's not venous kind of backflow, it's serous fluid. You'll see this developmentally when you have the descent of testes, or you could see it secondarily to an inflammation of some kind. Often it's painless and it's enlarged fluctuant scrotum. Most commonly though, you'll see this in infants. Most of them, they will spontaneously resolve in 1 year. 1 second. And with infants, when you see congenital hydrocele, not acquired hydrocele, but a congenital hydrocele appear, you'll see it's because incomplete obliteration of the processus vaginalis. So it's a developmental issue with that obliteration process that affects essentially the scrotal swelling. Yes. Varicocele. Yeah. If you had hydrocele, typically doesn't affect fertility. Varicocele is most common. It's blood backflow. You're affecting actual sperm development. So varicocele is the one we would watch out for the most. And it's most of the time left-sided, almost always. And that's based off of that drainage pattern. Yeah. IVC. Yep, exactly. Perfect. Perfect, perfect. And then you have, do I have a spermatocele on this page? Let me see. Okay, we'll get there. All right, then we go to our hematocele. All right, so we had our varicocele, venous stuff, our hydrocele, serous fluid, more watery fluid, and now our hematocele. Now this is blood in the scrotal sac. Typically, we see this due to trauma. We could see this spontaneously in atherosclerosis, diabetes, scurvy, syphilis, tumors. This will not transilluminate with light, a hematocele. But think about hematocele as more trauma-based or secondarily to some other condition. Torsion, testicular torsion is a medical emergency, especially in kiddos, due to the potential loss of testicle. If you have actually the testicle that's torced, think about ovarian torsion and you cut off blood supply, that can lead to actual testicular loss or death or necrosis of tissue. It can be spontaneous, especially if we see that potentially in children. You can see a spontaneous testicular torsion or traumatic, which is more probably common, but either can occur. Okay. Seminoma is going to be your most common tumor with cryptocurism. This is going to be the most common tumor associated with lack of descent of testes or inappropriate or inadequate descent of testes. It is malignant, but it is the best prognosis of testicular tumors. You can see metastasis to lymphatics. Some can show increased HCG production, but it will typically be painless and you'll see homogeneous, so overall testicular enlargement. So most common testicular tumor. I think that's all I would say about that. Fried egg appearance on histology. That's kind of pathognomonic. Hi. I have more on some other tumors later, so we'll just stick with seminoma for now. But I do have a couple words on prostatitis. So acute prostatitis is typically caused by bacterial infection versus chronic doesn't have to. Gonorrhea and chlamydia, again, in men under 35, and men older, E. coli is more common. So kind of looks similar to our epididymitis and our orchitis, right, and our agents. The younger men we tend to see more of the STDs, sexually transmitted infections, as being the etiology. Older, we're looking at E. coli or bacteria that could be present maybe from the rectal tract or things like that. But could you see it in both? Absolutely. You can see an older man present with gonorrhea as a cause of acute prostatitis. So it's not foolproof. You'll typically see more symptoms of an actual infection with your acute presentation. Chronic prostatitis, on the other hand, is inflammation of the prostate gland. It's more gradual, more insidious onset. It can still be associated with pain. It'll continue for a more prolonged period. It can have more subtle symptoms. Most common etiology, if bacterial, is going to be E. coli, although you could also see Proteus, Enterobacter, and Klebsiella. You can also see a non-bacterial cause, especially secondary to a previous infection, a nerve issue, or chemical irritation. So it's not always a chronic infection. That's the etiology for chronic prostatitis. Then when we get to other prostate conditions, BPH comes up, benign prostatic hypertrophy or nodular hyperplasia. We'll see nodules that are distinct in the periurethral area and the middle and the lateral lobes. You could see partial or complete obstruction depending on the size, the shape, and the location of the enlargement. This can be associated with mild or elevated PSA levels. And then dihydrotestosterone can also lead to hyperplasia or an increased growth. The other pieces about BPH that are interesting, typically you see this in your elderly patients more commonly. An issue is obviously compression of the urethra. So there we get our symptoms. We can see issues with starting or stopping stream, urination dribbling. We can see issues with nocturia, frequency of urination, even sometimes urinary pain. So if you're seeing any of those lower urinary tract symptoms, the LUTS symptoms, think BPH, benign prostatic hypertrophy. I often see them pull this question and try to get you to associate with infection. So have like a BPH prostatitis kind of case where there's enlargement, but maybe no signs of infection. They're giving you LUTS symptoms. So they're trying to pull you down the prostatitis pathway. But in reality, it's just enlarged prostate. It's hypertrophy or hyperplasia of the prostate. When we get to prostate cancer, it's the most common cancer of men. It's typically in the posterior lobe, and you'll see hematogenous spread if spread occurs to your lumbar spine, although you can see it to other bony regions as well. But the common hematogenous spread is to the lumbar spine, the low back. Higher incidence with family history. So kind of like our female cancers, like breast cancer, ovarian cancer, cervical cancer. If you have a primary female relative that has a cancer in their history that's of that nature, you have an increased risk. Same goes with males in this instance. Because it's in the posterior lobe, that's why it spreads posteriorly typically when it is metastasized. I think those are my main pieces to say about that. Typically associated more with old age. Yep, those are my big ones. Okay. Now we get to kidney stones, nephrolithiasis. So kind of leaving some male repro, getting back into the kidney, and then we'll go back to female repro. So we're kind of jumping around. So nephrolithiasis, pain, calcium stones are most common. Uric acid stones are less common, but asked about a ton on the NPLEX exam. So calcium stones, most common stone. So if they calcium oxalate specifically, so if they ask you what's the most common stone type, say calcium oxalate. Uric acid stone, anyone know what that one's more associated with? Gout, because uric acid buildup, great. Awesome. Anything else? Any other thoughts? Okay, we'll get there. We'll get there. But yes, gout, uric acid, you should think gout. So good. I'm glad we got there. 10 cherries a day. What? Low pH? Not so much. We'll circle back. We'll circle back. Okay, so once a patient has a stone, they have a greater risk of recurrence. No calcium oxalates, the most common. Calcium combines with other stuff to form the stone. Oxalates present in certain foods. That's why we get asked about this all the time, the spinach, the leafy greens, et cetera, et cetera. We could do a stone analysis to find out what's in it. Proteus or staph infections can cause alkaline urine, which can increase crystal formation. So that's your two bugs I want you associated with your stones is Proteus or a staph infection, but really Proteus. You have a Proteus infection, UTI, you have low pH or you have high pH, alkaline pH, you raise your pH level, that can actually increase or set you up for stone formation. A stone that's large and obstructive is called a staghorn calculi. Think about like staghorn, like you'd find on animals. And then our uric acid calculi, like I said, gout, radiolucent, so it looks a little bit different. So these would be the ones I would want you to know. Calcium oxalate, radiopaque, most common. Radiolucent, think about uric acid calculi, gout as like your lowest or your least common, but most radiolucent. Staghorn calculi is going to be obstructive, inactual to renal pelvis. And Proteus or staph infection will cause more basic urine, alkaline urine, which can increase crystal formation. Okay. Those would be your big pieces of the puzzle to associate. Okay, interstitial nephritis. You can have acute. This can be temporary lesion, most often associated with the effects of meds on the kidneys. You also could see chronic or progressive as well. The meds, you probably won't need to know for the purposes of this test, but there's many that can affect. Our antibiotics are a big class, specifically the penicillin class. Interstitial nephritis essentially is causing reduction in kidney function. This could be ranged to mild or even as severe as acute kidney failure. We can see the big kind of hallmarks are either an increase or decrease in urine output. You could also see, depending on the level of severity and the effects on the body, like effects on reabsorption or excretion, mental status change. Sometimes rash, really swelling of the body is due to fluid retention and blood in the urine. So looking at a few specific types, hereditary chronic nephritis or Alport Syndrome. This is an X-linked disorder, X-linked recessive. It's going to involve kidney damage where you'll see hematuria. You also could see defects in sometimes hearing and vision loss. And this is due to a mutation in a gene that forms collagen. It will cause a chronic glomerulonephritis, and you'll see destruction of glomeruli. So you're going to see issues with filtration then, if you have destruction of that actual structure. Polycystic kidney disease, we think about polycystic ovarian syndrome, lots of cysts in the ovaries. This is loss of cysts in the kidneys. It's inherited. It enlarges kidneys and affects their function. So we have these large cyst-like structures. We're going to have a harder time with our nephrons doing their job in filtration. The cysts can be associated with lots of different things. Sometimes you'll see aneurysms with blood vessels in the brain as an association, diverticula of the colon, cysts in the liver and other places. But you also could just see cysts in the kidney on their own without any of these other associative symptoms. There's about up to 50 people, though 50% of people that have polycystic kidney disease also have cysts on their liver. So if you have lots of cysts, you can also have one cyst. A single renal cyst is different than polycystic kidney disease. This is often an incidental, non-cancerous, painless finding. that could cause hematuria. Okay. Now everyone's favorite and least favorite, nephrotic and nephritic syndrome. Okay, nephrotic syndrome. This is where you see lots of protein in the urine, lower blood protein levels because it's leaving in your urine. You see potentially high cholesterol levels. You're going to see edema and swelling. Urine could also have fat with nephrotic syndrome. There's a lot of different things that can damage the kidneys and cause nephrotic syndrome. Thinking about the basement membrane of your glomerulus as being really the site of damage. Membranous glomerulonephritis. This will lead to those essentially holes, those fenestrations to be bigger to allow for proteins to escape into the filtrate, into the tubules. And that's what's happening here. If you affect the podocytes, the feet processes that are blocking those fenestrations, those holes in the capillaries, if you destroy those, that's that basement membrane. If you destroy part of that, or if part of that gets damaged, you're going to allow larger molecules to be filtered into the urine. And then if they get filtered in, they have a harder time getting removed back out later. So big edema, you could see ascites, foamy appearance of the urine is due to proteinuria, and then weight gain is really from fluid retention. Causes and incidence and risk factors, membranous nephropathy, nephrotic syndrome, membranous glomerulonephritis. You can see these all used interchangeably sometimes on your test, but you'll also, specifically membranous nephropathy, you'll see a thickening of the capillary wall in the basement membrane by immune complexes. What are immune complexes from? What type of hypersensitivity? 3, great, good. Unknown cause. One of the most common causes, though, of nephrotic syndrome is this essentially immune complex deposition. The unknown cause is because it's not directly from kidney damage. It's an outside etiology. It's outside. It's not just idiopathic random immune complexes. It's from a type 3 hypersensitivity that's causing that damage to the basement membrane. You could see asymptomatic excretion of protein in the urine, but almost always there's damage to that membrane that's causing this condition. The filtration rate will remain normal. So that's a kicker that will differentiate from some of the other conditions like our interstitial nephritis. Membranous nephropathy, like I mentioned, thickening of the capillary wall. You can see it being a primary renal disease of uncertain origin, but oftentimes it's associated with other conditions. The type 3 hypersensitivity, it's often not just damage to the membrane directly itself at the kidney as the primary lesion. So some systemic disorders that can cause it. I listed kind of a bunch here. There's way more others. There's also a risk of exposure to a bunch of substances and medications. I would worry less about this list. I would worry more about this list. Okay, IgA nephropathy, Berger's disease. Oh, wow. Okay, I got really excited. Sorry. Okay, woo! Getting excited at like 3 a.m. when I made this. No, I didn't make it at 3 a.m. Maybe last year I did. IgA nephropathy. So primary recurrent hematuria, you will see immune complexes, specifically IgA, complement 3, and fibrin antigens in a granular pattern in the glomerulus. You'll see both macro and microscopic hematuria and only mild proteinuria at this stage for this condition. This is a progressive condition over 20 to 30 years, where over time you'll see glomerular destruction, loss of renal function, and hypertension. But initial onset, you'll see maybe some mild hematuria and mild proteinuria, much less than nephrotic syndrome, where you're seeing gross hematuria or gross proteinuria. Berger's disease also, you can see some skin abnormalities. So you can see similar deposits here. We can see these IgA deposits over on our like fingers and our toes. You can see similar deposits in Hematuria purpura, in lupus and eclampsia, as well as other causes of glomerular disease. So this is not only associated with Berger's. Risk factors, personal or family history of IgA neuropathy or nephropathy, Hematuria purpura, which is vasculitis affecting lots of parts of the body. And it can occur anyone of all ages, but it tends to affect males in teens to 30s the most. That's your most common population. It will be a slow progression, and in some, it doesn't progress at all. It's so people are able to survive or live with it. But you can, if you obviously are destroying that glomeruli over time, you could see issues with blood pressure regulation and management, issues with more protein in urine, and you could develop end-stage renal failure, but it's only about a quarter of people that do, more rare. Because we mentioned it twice, henoch-Schöllen purpura, just a reminder, typically diagnosed in kids. You see those purpuric skin lesions on your extensor surfaces of your extremities and on the buttocks. It's due to IgA precipitation. Typically, the trigger is a respiratory infection, and you can have hematuria that will come and go for years post the actual infection. Okay. Goodpasture syndrome is anti-glomerular basement membrane nephritis. So this is a rapid progressive form of glomerulonephritis, whereas some of these others were more insidious or long-term in onset. This is rapid. Goodpastures will be progressive decrease in kidneys' ability to function. You'll also see the cough with bloody sputum. So you get the lungs and the kidneys with Goodpastures. Antibodies collect in both areas, the glomerulus and the alveoli, causing both glomerulonephritis as well as bleeding in the lungs. So you have a whole host of symptoms, but if you hear anything about bloody cough and kidney dysfunction, Goodpasture syndrome should pop up into your brain. You also could hear it listed as antiglomerular basement membrane nephritis. They could leave out Goodpasture syndrome and list it as such. This is just describing what that antibody is specifically to the kidney. It's not fully correct because it's not really including the alveolar component or alveolar antibody, but I have seen them use these words interchangeably before. A few pieces on renal or urinary cancers before we take a break before our last hour. Adenocarcinoma or hypernephroma. This is more associated with painless hematuria, with smoking. It's typically localized to the upper pole of the kidney. It's typically solitary and typically one-sided. It will metastasize to lung and bone most of the time before you're symptomatic. So that is where this becomes dangerous. If it was found incidentally, because it's typically more localized and unilateral and solitary, it could be very treatable. Often because it's found after it's progressed, that's why it is more dangerous. The Wilms tumor is the common primary renal tumor in kids. It is genetic in nature, and you typically see it diagnosed age 2 to 5. So if you're asked, what is the most common primary renal tumor? It is Wilms tumor. Primary meaning it didn't metastasize from anywhere else. It started in the kidney. Painless hematuria, really good prognosis, good survival rate. Typically unilateral, almost always unilateral, yes. Some other tumors, malignant ureteric tumors, so issues with the ureters. Primary tumors are rare in this region. Typically, you're dealing with metastatic disease, and the cells involved is going to be transitional cell cancer. Obstruction is your main complication, so you'll see painless hematuria as a symptom. You also could see urinary reduction or backflow into the kidneys, so then swelling and edema and kind of those issues. A post-renal syndrome, right? A post-renal nephritis or inflammation. But this is typically a rare primary tumor. This is going to be from metastasis. And then tumors from the bladder or of the bladder, painless hematuria, again, like I said, risk factors, smoking is a big one, even exposure to passive smoke, passive smoking exposure, industrial solvents. These are typically transitional cell tumors. You can also see benign papilloma. 90% of them are transitional cell carcinoma. So that's the majority. You can see a squamous cell carcinoma here, but most of them are transitional cell carcinoma. Why? Because the bladder is lined with transitional cells, right? That's the most common cell type in the bladder. You can see HCG in the urine. These types of tumors tend to recur after excision, so they can be pretty deadly. And then renal cell carcinoma up back into the kidney. This is kidney cancer that involves cancerous changes in the renal tubule cells. It's the most common type of kidney cancer in adults. So we had Wilms tumor for primary cancer type in kiddos. We have renal cell carcinoma for adults. Smoking greatly increases risk for RCC. You have lots of different symptoms that can occur. A lot of them are classic cancer symptoms. You could see kind of some of these other associations. I wouldn't worry about the symptoms at this point. I would just have the associations that's the most common cancer of the kidney in adults. Okay, did it. We have 1 more hour to get through. Take a 10, come back at 3 till, so 10:57, and then we will finish up repro. We'll go through repro cancers. We'll probably finish early so we can have some time to chat if you have questions. Okay. Renal failure is kidney failure, so it is renal, but the etiology of the kidney failure could be pre-renal due to something prior to the kidney, then causing kidney dysfunction or damage. It could be intrarenal, something from the kidney itself, or it could be post-renal. We tend, though, to use acute renal failure as the description of pre-renal, intrarenal, or post-renal, because acute renal failure is typically when we're seeing these terms, because this is something that can be fixed, right? It can be corrected. Chronic kidney failure is a progressive chronic condition, not necessarily associated with things that we can fix or correct. Once that chronic renal failure has started, oftentimes we can just halt it in that stage. We're not necessarily improving it. Renal failure is used for both acute and chronic renal failure. Yeah, thanks.